Good morning, everybody, and welcome to this lecture on anti-Parkinsonian agents. Now, before we can go to the Parkinsonian agents, we first need to know what neurodegenerative disorders are. So neurodegenerative disorders is basically a neurodegenerative disease that results in the death of neurons. It affects your central nervous system, so basically your brain, and it affects it in such a way, or affects it in such a way where you get progressive loss of neurons and brain cells in your central nervous system. This is a progressive disease, the neurodegenerative disorders, and it continues to worsen as time goes by. Some of the examples of neurodegenerative disorders include Parkinson's disease, Alzheimer's disease, and Huntington's disease. There are also a few others as well, like, for instance, Machido-Joseph disease and stroke that can also fall under this umbrella term for progressive loss of structure and function of neurons, thus neurodegeneration. But in our lecture, we will mainly be focusing on agents that work against Parkinson's disease, and we'll learn a little bit more about the medicinal chemistry of these anti-Parkinsonian agents. So if we look at Parkinson's disease, one very famous person that suffered from Parkinson's disease was the boxer Muhammad Ali. Also, the actor Michael J. Fox suffered from Parkinson's disease in their life. Then, if we look at some background on Parkinson's disease, idiopathic Parkinson's disease or primary classical Parkinson's disease is progressive neurodegenerative disorder. And make a note of this, Parkinson's disease is associated with a decrease in dopamine levels in certain parts of the brain. This decrease in dopamine gives you all of these cardinal features, signs and symptoms associated with Parkinson's disease, like, for instance, resting tremor, rigidity, bradykinesia, postural instability. And all of these things happen because there is a decrease in this neurotransmitter dopamine that regulates all of these different bodily functions. So that's the reason why you see some of these signs and symptoms. You can also see that it affects mainly the elderly, and people over the age of 60 are at risk because they have a high prevalence of developing Parkinson's disease. Now, it must also be remembered that there's no cure currently for Parkinson's disease. The drugs that we currently have on the market is mainly symptomatic drugs. It treats the signs and symptoms. So the cornerstone therapy for Parkinson's disease is basically to increase dopamine levels. So you increase the levels of that dopamine neurotransmitter, and it aids in alleviating some of the signs and symptoms, but it does not stop the disease. We do not yet have what we call a neuroprotective agent that basically protects your neurons from further neurodegeneration, or even regenerative medicine that can possibly regenerate neurons, but that we're not at yet. So current treatment options are only symptomatic. Here you can also see it's just a visual representation of the signs and symptoms associated with Parkinson's disease. You can also get secondary Parkinson's disease that is induced by drugs or certain toxins. Take note of that. There are a number of risk factors. Age is probably the most important risk factor. There's quite a few other risk factors as well. An interesting one is also there's an inverse correlation between cigarette smoking and caffeine intake in case control studies, where they actually say that people who smoke and drink coffee has a lower prevalence of developing Parkinson's disease. And the reason for that is that cigarette smoking or nicotine and caffeine, if you look at their chemical structures, they have the ability to block an enzyme known as monoamine oxidase B. And this enzyme is known to cause metabolism of dopamine. And with cigarette smoking and caffeine, by blocking that MAO-B enzyme, it increases dopamine levels because the MAO-B enzyme can no longer metabolize dopamine into inactive metabolites. So that's why they reckon that cigarette smoking and caffeine may, in some cases, assist against Parkinson's disease. I'm not saying that you should start smoking so that you don't get Parkinson's disease. It's not good for your health. I don't think you will actually even reach the age where you develop Parkinson's disease if you start smoking. So please don't do that. So please just take note of the risk factors. I've also at the bottom of my slides, I've given you my narrative, basically what I'm saying in these slides. Please make sure to take note of this. Also, I've given quite a few tips in my notes at the bottom of my slides. So please make sure that you go through that. So the therapy of Parkinson's disease, the main thing with Parkinson's disease therapy is the replacement or the increase in dopamine levels in the brain. And we can do that by increasing the synthesis of dopamine, like for instance, levodopa. Levodopa is a bioprecursor prodrug of dopamine. As it gets converted to dopamine in the CNS, and increases dopamine levels. Stimulation of dopamine release, like for instance, our dopamine receptor agonists. They bind to the dopamine receptor and they can stimulate dopamine release. Another drug, amantadine, also can cause dopamine release. Direct stimulation of dopamine receptors. Again, that's where the dopamine receptor agonist comes in. They stimulate the dopamine receptors in the brain, and it leads to then more of the dopamine getting released. Decrease in the reuptake of dopamine in presynaptic sites. So we're stopping the reuptake of dopamine, thus you have more concentration of dopamine in the CNS. And one drug that is used to decrease the reuptake of dopamine is also amantadine. So amantadine can also be then referred to as a multifunctional agent because it can stimulate dopamine release and it also decreases dopamine reuptake. Please take note of that. Then there's other drugs also that decreases dopamine metabolism, also known as catabolism. And those are the drugs like your dopamine decarboxylase inhibitor, carbidopa, your COMT inhibitors, catechol O-methyl transferase inhibitors, like for instance, tolcapone and entacapone, and your monoamine oxidase B inhibitors like selegiline and prasagiline. So those are the main therapeutic strategies or therapeutic agents that they use in the treatment of Parkinson's disease. And there are numerous combinations of these drugs that they prescribe to patients. It's very rarely where you will only have one drug that gets prescribed for Parkinson's disease. They usually use a polypharmacy approach where they use a combination of these different drugs to manage the Parkinson's disease. Then further therapy of Parkinson's disease, let's have a look at the first drug class. It's the levodopa. And you will see here, I've already indicated that levodopa is used in combination with carbidopa. And that drug is then known as cinnamide. So if we look at the metabolic pathway of dopamine, so that's dopamine. And you can see that dopamine can undergo metabolism or catabolism via the enzyme monoamine oxidase, and specifically monoamine oxidase B, into inactive dopamine metabolites. Dopamine can also be deactivated by our COMT enzyme into inactive metabolites, and even dopamine beta hydroxylase can also then cause dopamine to catabolize into inactive metabolites. We know that levodopa is a precursor, bioprecursor prodrug of dopamine. And you can see what happens here. Levodopa can cross the blood-brain barrier. It reaches the central nervous system, and there's an enzyme known as dopamine decarboxylase that then converts L-dopa into dopamine, and thus you have higher levels of dopamine in the brain. So levodopa has been a cornerstone therapy for Parkinson's disease, and you can read up here on my notes on how levodopa works, as well as there's a question that you need to answer, and it's important for the exam. So levodopa was already identified in the 1950s, and they found that it could restore brain levels because of dopamine, because it can cross the blood-brain barrier and be converted into dopamine by the dopamine decarboxylase enzyme. Then if we look at it here as well, here it's just basically what I've already said, where you have L-dopa. L-dopa can latch onto an L-amino acid transport system because it's in the correct stereochemical configuration to bind to the L-amino acid transport system. We did discuss this in stereochemistry as well. And then once it uses this transport system to cross the blood-brain barrier into the CNS, there's enzymes known as aromatic L-amino acid decarboxylase enzymes, that then in the CNS converts levodopa into dopamine. You have higher concentrations of dopamine. Thus, you can then treat the signs and symptoms associated with Parkinson's disease. But like I've previously said, these drugs are rarely used individually. So the main drug that are used with levodopa is carbidopa. Carbidopa is a peripheral dopamine decarboxylase inhibitor. So if we look, for instance, at peripheral levodopa, you can see here that levodopa, before it crosses the blood-brain barrier to reach the CNS, can undergo catabolism by the dopamine decarboxylase enzyme in the peripheral system into dopamine. Even drugs or enzymes like the catechol O-methyl transferase, that enzyme is also part in the peripheral. So that can then also cause the conversion of levodopa into inactive metabolites. So 3-OMD is 3-O-methoxy dopamine. It's a deactivated form of dopamine. So you can already see here that usually what happens is that they prescribe levodopa with carbidopa to block the dopamine decarboxylase enzyme in the peripheral, so that levodopa doesn't get converted to dopamine before it crosses the blood-brain barrier. Sometimes they prescribe catechol O-methyl transferase enzyme inhibitors as well to further protect dopamine or levodopa in the peripheral, so that it doesn't convert into 3-O-methyl dopa. So if you protect levodopa in the peripheral system, then enough of it will cross the blood-brain barrier. And once it reaches the central nervous system, now you have your dopamine decarboxylase enzyme that can convert it to dopamine. But you still have other enzymes like, for instance, COMT, that can still convert 3-O-methyl dopa or levodopa into 3-O-methyl dopa. So you will see that a lot of times with levodopa, they will prescribe it with carbidopa to protect it in the periphery from catabolism. And they will prescribe levodopa with carbidopa with a COMT inhibitor like tolcapone or entacapone to protect levodopa even further from catabolism in the peripheral as well as in the central nervous system. So you can see these are strategies that they use to increase levodopa concentration, but then still have the dopamine decarboxylase enzyme to convert levodopa into dopamine. You will see that carbidopa is a peripheral dopamine decarboxylase inhibitor. So it only works in the peripheral, but not in the central nervous system because it can't cross the blood-brain barrier. So levodopa then still can get converted into dopamine. I did write some of it down here at the bottom of my slide as well. There are quite a big number of side effects for levodopa. Please take note of these. There's also certain limitations of why we can't use levodopa. One of the main things is that efficacy tends to decrease as the disease progresses because there's less and less dopamine in your brain as more and more neurons die. So you need higher and higher concentrations of levodopa to still control the disease. But then up to a certain level, the levodopa dosage gets so high that it leads to quite a number of side effects like motor fluctuations, dyskinesias, neuropsychiatric problems. Remember that if we increase dopamine levels too high, what happens then? Then we lead to neuropsychiatric problems like schizophrenia, schizophrenic type symptoms. So sometimes it does happen when you treat a patient with levodopa that suffers from Parkinson's disease, that you get the balance of dopamine wrong and it gets too high. And then what happens is then you lead to these neuropsychiatric problems as well because of very high levels of dopamine. So that's just some of the limitations are associated with levodopa. Then we get some other drugs as well that we use in combination with levodopa and carbidopa. The first class is our monoamine oxidase B inhibitors. If we go back to the metabolic pathway of dopamine, you'll see dopamine here. There's an enzyme known as monoamine oxidase and mainly monoamine oxidase B that converts or metabolizes dopamine into 3,4-dihydroxyphenyl acetic acid, which is a derivative of dopamine, but it is not dopamine anymore. So by combining a drug that blocks MAOB inhibition, then or block the MAOB enzyme, inhibit it, then you will have higher concentrations of dopamine when we just look at the metabolic pathway. So there are a few drugs that is currently on the market, known as seleginine and resagiline, that are used as monoamine oxidase B inhibitors in combination with in combination with carbidopa and levodopa. You will note that both of these two structures contain a functional group known as the propergalamine moiety. And this propergalamine moiety is a very important structural feature to give these drugs monoamine oxidase B inhibition. Without this structural feature, the drugs will be devoid of any MAOB inhibitory activity. So please make a note of this, that resagiline and selegiline, the main structural feature is the propergalamine moiety, and this propergalamine moiety is the reason why these type of drugs, selegiline and resagiline, are selective inhibitors of monoamine oxidase B, which inactivates dopamine catabolism in the brain. So does the MAOB increases dopamine levels because it decreases the catabolism thereof. And make a note that these drugs are used in combination with levodopa and carbidopa. Then we have some other drugs as well, the COMT inhibitors, tolcapone and entacapone. We go back to the metabolic pathway of dopamine. You can see dopamine can be metabolized by COMT into inactive dopamine metabolites. And even levodopa, as we've previously discussed, that the COMT enzyme can convert levodopa as well into inactive metabolites. So by blocking the COMT enzyme, you will then increase both levodopa levels as well as dopamine levels. So again, when drugs are combined, they usually combine levodopa, carbidopa with a COMT inhibitor like tolcapone and entacapone, and if necessary, they may even prescribe a monoamine oxidase B inhibitor to really protect the dopamine in the brain from catabolism and increasing that concentration high enough to treat the signs and symptoms associated with Parkinson's disease. The two drugs that are used as COMT inhibitors is tolcapone and entacapone. Please make sure to read up on the mechanism of action. Very important for tolcapone and entacapone. Tolcapone mainly acts in both the brain and the periphery, whereas entacapone is mainly in the periphery. So if you want a drug that detects both levodopa and dopamine in both the brain and the periphery, then you can use tolcapone. Tolcapone is also a longer duration of action compared to entacapone. So please make note of this. This is quite a nice MCQ question to ask. The COMT inhibitors are also known to cause certain adverse effects. Please make a note of this, and maybe a nice MCQ question. Then we also have drugs that increases dopamine release and decreases dopamine reuptake. And these two drugs are amantadine and memantine. So the way that amantadine and memantine works, it blocks a receptor in the central nervous system in our cells, known as the NMDA receptor, the N-methyl D-aspartate receptor. And this receptor gets activated during neurodegeneration. So if you are prone to neurodegenerative disorders like Parkinson's or Alzheimer's disease, there is a massive increase in glutamate in the brain. This glutamate then can bind to the NMDA receptor. It activates this receptor, and then there is a increase in flux from the outside of the cell to the inside of the cell of calcium, because this NMDA receptor is a calcium channel receptor. Once you open this channel with glutamate that binds to it, then you open the channel so that there's an excessive flux of calcium. This calcium then accumulates within the cell, and it accumulates to very high levels. And it activates a number of processes, and the main processes that it activates is the generation of free radicals. So it causes the generation of oxidants. These oxidants then basically act like as you peroxide your hair becomes white, and it looks as though your hair then basically dies. So the same thing that happens here is these oxidants causes like a oxidative reaction, like you peroxiding your hair, and then it causes these neurons to die. So by blocking this NMDA receptor, you may then decrease the amount of calcium, and you will also decrease the amount of free radicals that gets formed in your cells, and thus then you stop the process of neuronal cell death. So the two drugs that are currently on the market that works in as NMDA receptor inhibitors or blockers is amantadine and memantine. These two compounds are known as polycyclic cage compounds because the adamantane structure looks like a small bird cage. This drug, although it has a primary amine that can be protonated at physiological pH, so that is known as a drug that could not possibly cross the blood-brain barrier because protonation of the amine causes it to be highly water-soluble. But because of the polycyclic cage-like structure of this molecule, you can see it contains a number of carbons within this box-like or bird cage-like structure. It increases the lipophilicity so high that it's more than 2. So even though you have a primary amine, this drug is still lipophilic enough to cross the blood-brain barrier. That is actually quite an important thing to note of why this drug can still cross the blood-brain barrier, even though it has the primary amine. Another important thing is that this drug is quite stable, and with metabolism studies, it's shown that this drug is excreted in the urine unchanged. I did try to narrate it here at the bottom as well for you, writing it down. Please make sure to go through my notes at the bottom of each slide. In the therapy, then dopamine receptor agonists, we also get dopamine receptor agonists. It's primarily dopamine D2 receptor agonists. You can take note of the dopamine receptor agonist drugs, like, for instance, pramipexole and ropinirole. This is just for noting. Here I've shown you some of the structures. It's not necessary to memorize the structures. This is just an example of certain dopamine receptor agonists that are used in combination with levodopa and carbidopa and so on to effectively treat Parkinson's disease. We also get other dopamine receptor agonists like pergolide and bromocriptine. It is important for you to be able to compare and contrast between these two different dopamine receptor agonist classes. You will see that this is an ergot derivative, and this one is more of a derivative of the alkaloids. And you will see I try to explain it here. This is maybe just for noting and maybe for a short MCQ question. We also have further dopamine agonists that you just need to take note of that could potentially be used in combination with the other dopamine, with the other Parkinsonian agents. So that brings me to the end of the Parkinson's lecture. I wish you good luck. Thank you.